Welcome back to this PTAC public meeting. I'm Grace Terrell, Vice Chair of PTAC. We will now continue with our discussions on telehealth, a theme we have found across various proposals. Those of you who joined our earlier session had the opportunity to hear from many of those submitters. Now we have convened a panel of experts in telehealth from a variety of organizations. You can find their full biographies on the meetings page of the ASPE PTAC website. For this panel, we have several questions in the queue for each discussant to respond. We will work through each question, and I will likely vary who is called upon first to respond. I'll ask that each panelist try their best to keep the responses to just a couple of minutes or so for each. That way members can have the opportunity to ask questions before we move on to the next question. And for those who were part of the morning panel, you know that we were able to get through some, but not all of our questions. So we'll try to be a little more efficient now with this session if we can be. First of all, I'm going to ask if each of you could introduce yourself, your organization, and the area of expertise and perspective you will be providing. Because this is virtual, I'm going to prompt each of you individually. So Ann Tomlinson, please.
Hi, thank you very much. My name is Ann Tomlinson. I am the CEO and founder of a research firm based here in Washington, D.C. called ATI Advisory. Also the founder of a caregiving organization called daughterhood.org. And my perspective that I'll be bringing today will be around the population that has a need for long-term care and experiences disabilities.
Thank you, Ann. Sophia Tripoli.
Hi, everybody. My name is Sophia Tripoli. I'm the Director of Healthcare Innovation at Families USA. Families USA is a leading national nonpartisan voice for healthcare consumers that is dedicated to achieving high-quality, affordable healthcare and improved health for all. So I'll be bringing the perspective of patient advocacy voice today.
Thank you, Sophia. Dr. Lee Schwam.
Yes, hi, my name is Dr. Lee Schwam. I'm a professor of neurology at Harvard Medical School, and I direct a Center for Telehealth at Mass General Hospital, as well as serving as the Vice President for Virtual Care and Digital Health at Mass General Brigham, which is our health system. I'm speaking from the perspective of a provider. I'm a stroke neurologist, but I'm also a health services researcher focused on quality of care and outcomes in stroke. So very excited to be here. Thank you.
Thank you, Dr. Schwam. Dr. Lewis Levy.
I'm Lou Levy. I'm the Chief Medical Officer for Teladoc Health, the leading telemedicine provider globally. My own background is practicing general medicine in the Boston area for the past 32 years and teaching over at Harvard Medical School. I was a full-time internist for 20 years and also taught in the residency program at the Brigham and Women's Hospital. I've been in digital health for the past 12 years and will be bringing the perspective of technology to the conversation.
Thank you, Dr. Levy. Dr. Chad Elamutu.
Yeah, thank you. It's a real pleasure to be here today. So I'm an assistant professor of urology at the University of Michigan and have multiple perspectives on the subject matter of telehealth. From a clinical perspective, I've been performing video consultations with my patients for many years, since about 2016. On the operational side, I'm the medical director of telehealth for my clinical department and have facilitated the growth of telehealth to about 40 providers and advanced practice providers and physicians. And then finally, probably most relevant here on the research side, I'm the director of the Telehealth Research Incubator at the Institute for Healthcare Policy and Innovation at the University of Michigan, where we're specifically studying the population level impact of telehealth on cost, quality, access, and the patient experience. Excited to be here today.
Thank you, sir. Dr. Sanjeev Arora.
Well, thank you for this opportunity. My name is Sanjeev Arora. I'm a gastroenterologist by profession, a professor at the University of New Mexico, and a founder and director of the ECHO Project. ECHO Project is a way to democratize knowledge and bring best practice care to underserved people all over the world. We are a hub and spoke network and operate 1,000 networks in out of 41 countries with learners in 158 countries. And I'm here to represent how The ECHO model of telehealth can be used to improve healthcare access for specialized care in the United States. Thank you.
Thank you. And finally, Dr. Chuck Zonfa.
You don't see him, Grace.
I think I seem to be having technical difficulty with my video, so I'm trying to troubleshoot.
Okay, we can hear you, sir. At the bottom, is there a little button where it says where you can flash open to where you can show your video?
There is.
Why don't you just go ahead and introduce yourself since we can hear you, and then I'll go ahead and get the questions started.
Okay. So as I was saying, I'm Chief Medical Officer at Summa Care. I'm a OBGYN by trade. The current practice that I do is overseeing the residents in the Women's Health Center here at Summa Health. We are an integrated provider-owned health system that includes a hospital system, an employed medical group, as well as an ACO and the health plan. And happy to be here and participate. And I am representing the payer side of the house.
Well, thanks to all of you all. And I am going to switch to your first names now, so I won't mispronounce anything anymore if I have, as we continue this. So I'm going to start with question 1. And so it is, for each of you, given your recent experiences from the public health crisis, can you comment on what you have observed and what might be the lessons learned broadly from your perspective, be it patient, provider, policy, payer, and so on? So let's start with Sophia and then with Anne, who can provide for us perspective of patients and individuals who may have experienced a change in access to services, as well as improvements or even barriers associated with recent care virtually. So Sophia, if you could start, and then Anne, and then I'm going to call on the rest.
Thank you very much. So there's no question, of course, that COVID-19 has had a catastrophic impact on American lives and lives around the globe. So far, we've lost nearly 200,000 American lives in the United States, with about 6.5 million cases of COVID-19. And of course, those numbers continue to increase every day. COVID-19 has also generated the most severe economic downturn that our country has faced since the Great Depression, which has resulted in substantial job loss and historical losses in healthcare coverage. We've witnessed at a terrible cost how critical it is to have a national testing coordination strategy that is led by the federal government in order to save and protect the lives of our nation's families amidst a global pandemic, and what it means and what happens when that leadership is lacking. The result has been a patchwork approach for governors and mayors across the country who are forced to make difficult decisions about keeping their residents safe while reopening their economies without the necessary tools and resources needed to ensure that children can go back to school safely, that their parents can go back to work without fear of becoming infected with COVID-19 and possibly losing their jobs and their health insurance, and so that our frontline and essential workers are able to safely keep serving our nation at a time when we need them most. We've also seen how the COVID-19 pandemic has further unveiled the harsh realities of existing disparities in health and healthcare in the United States, where Black, Latino, Native American, and immigrant communities have experienced significantly higher rates of infection and death. We've seen the impact of structural injustices interacting with public policy, such as variations in how counties are able to manage the outbreak and how the implementation of social distancing, testing, and economic support is reinforcing disparities. For example, for many communities, physical distancing is a privilege that is much less available to low-income communities. This includes low-income communities of color, where Black and Latino Americans are overrepresented in service industry jobs that have less access to paid sick leave protections, and where women of color are more likely to be considered essential workers. Not only has this type of work exposed workers to COVID-19, it has also increased the risk of exposure for their family members and neighbors, as people of color are more likely to live in multi-unit dwellings or intergenerational households. We've seen how important it is for the healthcare system to be accurately collecting data on race, ethnicity, and primary language at a minimum, and how much work we still have to do to get this aspect of our healthcare system functioning properly. This data is fundamental in being able to build a healthcare system that meets the needs of all the people it serves. And in the context of alternative payment models and value-based care, these data are critical for being able to build and implement equity payment incentives in healthcare. We've also seen the need for improved data sharing and data interoperability across and within the healthcare system, and with other sectors that impact our health, like our public health agencies and social services, et cetera. We've also seen that COVID-19 has sent shockwaves throughout the healthcare system, where our healthcare providers and organizations have taken drastic and heroic actions to orient workforces, modify facilities, prioritize critical services to provide effective and safe care for individuals with COVID-19, all while facing significant and continuous revenue shortfalls. These revenue shortfalls are the result of large drops in utilization seen across the healthcare system as stay-at-home orders rippled across the country. The drop in utilization has led to entire sectors of our healthcare system being at risk for going out of business. The most notable sectors, of course, being primary care, behavioral health, and dental care. Primary care practices have seen a decline of up to 50% in service volume, and pediatric practices have experienced 47% declines in service utilization. At a time when our nation's families need access to primary care most, our primary care infrastructure is at risk of collapsing. Telehealth services and capabilities, of course, have been expanded and scaled in a matter of days or weeks, which has allowed families access to critical healthcare services under shelter-in-place orders because of the public health emergency. And because of loosened regulations, the expansion and reimbursement of telehealth services has helped to generate some revenue in the short term, helping to keep many healthcare providers' doors open. But it is very important to note that the way that healthcare providers are paid is actually what's driving the healthcare system's current financial crisis. The predominant payment model in the United States, fee-for-service, offers no backstop when utilization drops. The limitations of fee-for-service economics were well understood before COVID-19, but now the impact of COVID-19 on our healthcare system has been a stark reminder that relying on volume to generate reimbursement and revenue as the predominant payment model in our healthcare system is not only unsustainable, but is also driving many practices to be on the brink of going out of business, which will only serve to reduce access to needed care for American families. One of the key system-level learnings we've seen is that providers and health systems who've participated in value-based payment have been more financially stable, particularly those in advanced alternative payment models who receive upfront ongoing payments not tied to fee-for-service. Practices using alternative payment models have been able to keep their doors open, to keep seeing patients during the public health emergency. They've also been able to better meet the needs of patients, the patients they're serving, because their payments are built to support a wide variety of capabilities that are not currently supported under fee-for-service, such as care coordination staff, patient engagement tools, including 24/7 helplines, data analytic capabilities, and of course, infrastructure needs to support telehealth, including remote monitoring and home-based care. Providers utilizing value-based payment have been able to leverage these capabilities quickly to implement an effective pandemic response, while fee-for-service providers have had to rely on the federal government to make rule and payment changes to move forward with these types of capabilities. And finally, the rapid expansion of telehealth has been an essential tool to allow families, children, and seniors to continue receiving access to healthcare services during the pandemic. However, patients still continue to face substantial barriers to accessing telehealth and virtual care services, including lacking access to internet and broadband services, lacking access to a cell phone at all, or a phone or computer with video capabilities, not having access to language interpreter services when using telehealth and virtual care services. And then finally, it's very important that as we're experiencing right now during the public health emergency, that we need a really concrete, sophisticated way to ensure that telehealth services and virtual care services are meeting quality standards to ensure that families are receiving high quality telehealth or virtual care services. Thank you.
Thank you, Sophia. Ann?
Thank you. Thanks for having me. And I'm really just very appreciative and of the acknowledgement that in the opportunity to reflect the perspective of the population that has long-term care needs, and just exciting to see that incorporated more and more into these kinds of conversations. So I just want to start quickly by just level setting on a couple of things. I think sometimes when we hear the words long-term care, we think of nursing homes, and especially during this public health emergency, the nursing home setting and assisted living settings have gotten a lot of attention because of the congregate nature of that setting and the increased opportunity for infection and the higher infection risk associated with them. But really, when we use the term long-term care, what we're really talking about is a population that has a lot of difficulty performing really basic activities of daily living. So just, trouble with bathing, dressing, eating, and in 75% of the somewhere around 5 to 7 million people, older adults, who have that level, who have a need for long-term service support, 75% of them are about or a little bit more, are living in the community. So they're living in single-family dwellings. They're not living in nursing homes or assisted living. And so I just wanted to, kind of level set that this is, one of the kind of the pre-pandemic, one of the huge challenges that we've had in serving that population. And I should just say, having a need for long-term service and supports is highly associated with really high rates of hospitalizations and ER use, even when you hold constant the underlying chronic conditions that may have, set the stage for those functional impairments to begin with. So we know that population uses a lot of healthcare. We have struggled mightily over many, 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 many years to scale care models that serve this population effectively and actually reduce the use of the hospital setting. And I would say that's been true of the population living in the community. It's also been true of population living in nursing homes and assisted living. I mean, these folks have largely been stranded in the kind of, I would say in the like they're sitting on a little island in the middle of our care delivery system, trying to connect a lot of dots themselves. And we have really, really failed, I would say, to scale the kinds of care models that we know work. And all this is leading me to say that I think one of the most kind of encouraging things that we've seen as a result of the pandemic has been, at least in the spots of our care delivery system where there have been, really high functioning care models with lots of, interdisciplinary team, primary care led, where they have been, under some type of a risk-based payment model. They have been able to kind of really rapidly flip the switch. Sorry, my watch thought I was talking to it because I'm getting so animated. But they have been able to kind of flip the switch. What we've seen is that they have been able to kind of very rapidly deploy, and Sophia mentioned this earlier too, the telehealth technologies that they need in order to serve the population. And maybe so what's really exciting is that those care models in the past have been hard to scale, in part because they require a lot of investment and they require a lot of people, to make them work. They are interdisciplinary teams. They have a lot of different people on them. They're really focused on this population. Think of PACE, the PACE model. Think of some of the enhanced primary care models that we all hear about all the time. They require people to go to adult daycare centers or to clinics so that you can get eyes on and address changes in condition quickly, get ahead of the hospitalization. Now, all of a sudden, we are seeing that maybe actually that kind of a care model can be delivered through virtual care much more than we would have ever imagined before. And I've even had some PACE organization, leaders say to me, oh my gosh, maybe we can do this a lot more efficiently. So it's not just about being effective. Telehealth, of course, is helpful in being effective in reducing hospitalizations when you use it, but now we're using it and we're seeing that it's actually a much less expensive way to do very effectively maybe some of the things that we were doing before. So I'm really excited about the potential for virtual care to kind of help us really scale up the care models that we know have really worked to help address the needs of this complex care population.
Thank you. And now for our other panels, I'm going to start with the provider perspective from Lee, and then we're going to move on to Chad, Sanjeev, Lewis, and Chuck with what might have been the challenges, including those that may be associated with the particular population they serve, as well as the technical clinical practice or geographic limitations or barriers, and so on. So let's again focus this as much as we can on telehealth and technology as it relates to how the pandemic has changed it and how it might impact our care models. And I'm going to turn it over to you now, Lee.
Great, thank you. Well, I endorse everything that's been said up until this moment. Let me just make a few high-level additional comments. I think it's very important that as we build out these systems, we ensure that our data dashboards and the approaches we take to measuring quality and variation in adoption address social determinants of health, as was nicely outlined already. One additional element I would add to that is concerns regarding privacy and location tracking, which makes some of our patients resistant to the idea of downloading specialized applications to conduct video and prefer to conduct them in browsers that don't track their location. We have a challenge of balancing security with simplicity. The solutions need to be simple and easily accessible so patients can quickly connect with providers, but they have to be secure so that they don't increase the risk of inadvertent privacy breaches or so they deter fraudulent use by malevolent actors. We haven't seen a lot of that. We've heard a lot about it, but I think we need to make sure that we can create secure but simple solutions. We in our own health system have not seen any of the concerned overutilization. We saw underutilization. We saw significant drops in our ambulatory volumes, even though our virtual care solutions restored 60% of the volume. We did not see a rampant adoption of telehealth for frivolous purposes, which I know has been a concern among the payers. I think we also have to recognize patients don't just have limited digital literacy or English proficiency or access to technology. Some of our patients have cognitive, visual, or physical impairments. Certainly as a stroke neurologist, many of my patients would have trouble joining a video call alone. So I agree with the prior comments and those earlier in the day about the need to think about the environment of care around the patient, since we don't control that in a virtual environment if the patient's at home. I want to just make two final points. One is to emphasize the importance of audio-only services. It is really a health equity issue. I think we've discussed that repeatedly. If you pay at a lower rate or you don't pay, you're now going to build structural inequity into the payment system, and that is going to disenfranchise a lot of patients. Particularly effective for us during the pandemic, we're treating patients with mental illness or substance abuse disorders. Those individuals really benefited from the ability to reach out and connect audio only, as well as keeping pediatric patients out of the doctor's office when appointments were not needed to be in person, and therefore decreasing everyone's risk of exposure. Lastly, I think we haven't talked yet about the trauma, both to providers and patients, of the social isolation and loneliness that the pandemic engendered. And so virtual care solutions that we enacted in our system and others as well were designed to support team meetings, family interactions, medical interpreters at very important moments, goals of care conversations, decisions about life-sustaining treatment. They were extremely meaningful, quite hard to measure, and generally not billable. So I think we have to understand that the avenues of care delivery that were created by virtual care sometimes were not just to replace an in-person visit, they were actually the only vehicle of care that was possible. So I think we learned a lot. We saved a lot of PPE. We reduced a lot of exposure to providers on the inpatient setting, and we made sure that patients had access. All of those things are only possible with the caveats that were previously mentioned, right? We need secure and predictable financing, and we need safe and secure and HIPAA-compliant platforms to do this in. Thank you.
Thank you, Lee. I'm going to move to Chad now.
Thanks a lot. Thanks for the opportunity again. And a lot of what has been said, I completely agree with Sophia and with Lee. I'll add my comments in. Some of it may overlap a bit. And I think I've kind of four big lessons that we've taken away from this experience. One is that there was a strong demand for patients and providers for telehealth, but it was not overwhelming. And so I think resistance to change is still a big issue in healthcare, as we know. So just some data to back that up. At our health system and also using national EPIC data, there was, as others have mentioned, about a 50 to 70% drop in outpatient in-person care, and only about 20% of that was really salvaged through telehealth. So most people were still deferring care during this time period. And as now we're looking into June, July, and August, and as health systems are becoming safer and allowing patients to come back in, most patients are still choosing in-person care. So, and a lot of providers are also kind of going back to the status quo of providing in-person care. So, along with, I'll second what Lee said, that there was really no evidence that we've seen so far or nationally have seen in any reports that there's been runaway use. Actually, even in this time period where there's maximum flexibilities during this public health emergency, what we're seeing is in-person care plus telehealth care reaching about pre-COVID levels. So nothing above that right now, at least, and time will tell if that changes. I think overall, we're going to probably expect about 20% of care delivered in the US to be virtual. I'll mention quickly my second point, that the degree of telehealth use that's clinically appropriate was really dependent on the specialty. So at our system, when we look at psychiatry, mental health, mental illness visits, almost 100% were converted, and they're actually staying converted to virtual care even now in August and September, while other specialties like orthopedics seem to be expanding more on the in-person side. I'll mention briefly with some data about the access issues. I think it's been said a couple times, but in addition to the digital divide that's been mentioned a few times, I will mention that there's also this perception among patients where the quality of care through telehealth may not be equivalent to in-person care. So we had a study by some colleagues that did a national poll of patients that are individuals that are aged 50 to 80 in June, and 2/3 of them felt that telehealth care wasn't equivalent to in-person care, and about 45% of those felt like the personal connection with their provider wasn't the same. So that's really important, and the digital divide obviously goes without saying is important. With the audio only and the other types of modalities, at our system, about 70% of the telehealth virtual care that was provided for patients that were over the age of 70 was done through audio. So, there's the digital divide portion of it, but then there's also this preference portion of it too, which is really important to consider. And the final point that I'll make on this is that in-person interventions, as we think about alternative payment models and reviewing proposals, in-person interventions also need to be accessible to achieve the outcomes that are desired through telehealth. So I'll give you an example. It's good to have a technology that monitors chronic disease and sends a signal to a doctor when there's a red flag. But what does that provider do when they get that red flag? If their answer is, look at it, and if they're concerned about it, send the patient to the ER, then you're not going to see any improvements in population health as a result of that. So the intervention, so is it the care team? Is it the home nebulizer, the home infusion? If that's not part of the bundle of things that are covered, then you're going to kind of go down the path of least resistance, which is to have the patient bumped up to a higher acute setting whenever you get these signals.
Thank you. Sanjeev?
Well, thank you. Thank you again for this opportunity. I'm going to talk about a very, very different use of telehealth than what you've heard so far. And I'm going to start with a little story to explain why this use is different. And one Friday afternoon, 18 years ago, I walked into my clinic as a gastroenterologist and saw a 43-year-old woman sitting there with her 2 children. And I asked her how I could help her, and she said she had hepatitis C and wanted treatment. She'd known about it for 8 years, and I asked her, why did she come now? And she said that she'd called my nurse and had been told she would require to make 12 trips to Albuquerque, 200 miles each way, and she didn't have the money for it. She didn't seek treatment, but now she was coming because she was having abdominal pain. But it was too late because she now had advanced liver cancer and died 5 months later. And I was asking myself, why did this mother of 2 children have to die? And she died because the right knowledge did not exist at the right place at the right time. And New Mexico at that time had 28,000 patients with hepatitis C, and hundreds of patients were dying every year for lack of access for treatment. And that's why I started Project ECHO. And millions of patients in our country are unable to access specialty care on a timely basis. And so we need to fundamentally reorient our healthcare system to enable us to quickly move new information and best practices from experts to providers at the front line, caring for communities, patients in their communities, and telehealth can play a very major role in this to make this happen. The COVID-19 pandemic has only underscored this urgency, and that's where ECHO comes in. ECHO, also called a technology-enabled collaborative learning and capacity building model, is a highly scalable platform to exponentially amplify the implementation of medical best practices in our nation. So what I'd done was I'd set up 21 new centers for treating hepatitis C, and we shared our treatment protocols, and once a week we would discuss these cases in a de-identified way. Soon they became experts, and the wait in my clinic fell to 2 weeks. We knew we had an effective model, so we expanded it to training other academic medical centers around the United States. And today we have 250 hubs in the United States in 48 states, training professionals in 20,000 organizations in the US for 70 different disease areas. And there's a very strong demand for these models. And what happens in ECHO is teams of experts at regional medical centers called hubs use one-to-many video conferencing to engage with local healthcare providers in weekly ongoing knowledge sharing, case-based learning, and telementoring. And hub and spokes learn from each other, and everyone's knowledge is improving, and we call it all teach, all learn. We published in the New England Journal of Medicine using this model. Rural providers could provide the same level of care as super specialists, and now we have 275 peer-reviewed publications showing it's effective. So for long, we believed that this can be used in a pandemic, but when COVID-19 came along, of course, for all of us, the world changed. We and our partners have now conducted almost 1,000 training sessions on ECHO, answering hundreds of questions, such as how to use personal protective equipment in the midst of a shortage, how much oxygen to deliver, what ventilator settings to use. We have trained more than 200,000 public health professionals, doctors, and nurses in the US on COVID-19. And what this means for us going forward is that we need a new way so that the right knowledge exists to the right providers. When COVID-19 came along, our providers did not know what to do with the patients. They didn't know how to intervene effectively. And so I'm making a pitch today that in addition to the traditional telemedicine, which is extraordinarily useful, and I endorse all the previous comments, we need a new model for technology-enabled collaborative learning and capacity building so that all the clinicians in the United States have access to the latest knowledge and can provide the best care in their local communities, whether it be with telemedicine or directly. And for this, we need alternative payment models, value-based care, or other innovative ways to make payment accessible for providers participating in ECHO projects and for academic medical centers that run ECHO projects. Thank you for your attention.
Thank you. Lewis?
Thanks so much. So I'd like to reflect a little bit about our experience to date and what we think are some of the more long-term implications. In Q2, we exceeded 2.8 million visits globally. In the US alone, we went from seeing about 10,000 patients a day to over 20,000 patients a day. Interestingly, about 60% of the individuals that were seeking care had never sought telehealth in the past. We also saw a very accelerated growth in individuals 18 to 30, particularly amongst men. Also would like to draw attention to the fact that we saw a great increase in terms of mental health visits, both individuals who had been diagnosed with a mental health condition, and this condition was exacerbated by COVID-19 and some of the isolation that other speakers have spoken to, as well as de novo mental health concerns. So year over year, we're over 10x where we were last year in terms of what we're seeing in the mental health arena. What does this all mean? We're seeing now that about 76% of consumers are quite interested in using virtual care. as compared to about 11% prior to COVID. Interestingly, about a third of individuals would even consider leaving their current physician for a provider who offered virtual services. But about 2/3 are really seeing the need to have the virtual care integrated very closely with their in-person care. What we're seeing from payers and employers is about 80% of large employers believe that virtual care will significantly impact the delivery of healthcare in the future, and that implementing more virtual care services and solutions is the #1 priority for large employer health initiatives. For healthcare providers, as has already been pointed out, 50 to 175% increase depending upon where you're looking. 64% of the providers are now more comfortable using telehealth than in the past. I would also like to draw attention to the recently released findings from the NCQA task force on telehealth policy, which was released this week. This was a effort where the NCQA brought together 23 stakeholders, including Teladoc Health, along with CMS, Kaiser Permanente, and a number of other organizations. And they basically felt very strongly that looking at this, that they felt that many of the concerns about telehealth, they studied what's been going on over the past 6 months and found, very interestingly that with the diminution in terms of wait times and issues around travel, that there was actually improved quality outcomes through telehealth and much greater adherence to care plans due to telehealth. As Lee has already highlighted, there was no evidence of increased utilization and increased volume of care. They felt that existing policies that are defining requirements around site of care should be eliminated. They also thought that there should be consideration given to universal provider licensing. So getting rid of this notion of you only have a Massachusetts license, so therefore you can't take care of somebody in Vermont, should be reevaluated. And also that many of the relaxations around HIPAA should be put back into place now in a post-COVID era. Certainly wholly endorse the issues that have been raised already in terms of addressing social determinants of health. As we have been very strongly advocates of that telehealth should always embrace an audio-only option. In terms of what are we doing in terms of expanding access, we've always endorsed audio only. We've always endorsed, having language lines and interpreters. And in terms of the elderly population, we've had a caretaker program where it basically can bring on, the family member to sort of help through the encounter with the elderly individual. We are on track to be doing over 10 million visits this year, and we think that critical to our success both today and going forward is always to have a careful attention towards the quality of care that's delivered. So we've been working very closely with the NCQA, the NQF, and a number of URAC and a number of other organizations to really ensure that as we are delivering care, we're constantly measuring the quality of care to ensure that with scale come improvements in the overall quality of care. So thank you so much, Anne, and happy to address any questions as they may arise.
Thank you. Well, I'm going to finish this part with Chuck, and then what we will do after you've had a chance to speak, Chuck, is I'm going to give the panelists time to ask some questions. One of the things that we are not going to be able to do is go through all 5 questions in this format. But as I'm listening to you all, you're very thoughtfully answering a lot of the other questions. So I'm going to mix it up after you've had a chance to talk, Chuck. We'll ask our commissioners if they've got questions, and then I'm going to ask for some rapid response answers on certain things from you if they're not answered with the from the things that the commissioners ask for. And then we're going to end with the final 10-minute question where you're really going to all give us your deepest insights as to how we're going to get everything better. So Chuck, back clean up on this for us. It's good to see you joined us on the video, and then we'll go to the next part.
Thank you, Grace. I think that I have effectively demonstrated that technology is not always easy or intuitive. So that was my goal, and I'm glad I achieved it. From the standpoint of what are the lessons learned, I think that there's a couple important ones. One is telehealth is a valuable tool, and I think we've demonstrated that over the past few months. And that I think it was said in the earlier panel that telehealth is here to stay, and I think we're still struggling with where exactly it fits. One of the things that strikes me in the conversation that was had earlier and even the one happening now is that we are starting to see a cultural shift. And I don't think we are as far down the continuum of a complete cultural change yet, but we have done 2 things. One is we've changed the culture of the providers, at least I'll speak for my own region here in Northeast Ohio, in that there was probably very slow adoption of telehealth services before the public health emergency, and we demonstrated that effective care can be delivered through a non-traditional face-to-face visit. And I think our providers rapidly adopted that technique and ran with it. In fact, I think that we saw at one point in time in the height of the pandemic, we probably had an adoption rate, especially when the office schedule started to drop dramatically, of about 60-some%. We have now normalized probably down to about 20% of visits within our own medical group. So I think that this cultural shift is changing on 2 fronts, one with the providers and the second with the patients. So in the fee-for-service world, we've traditionally had the only reimbursement that providers could get was through a face-to-face visit, typically. And what the pandemic has demonstrated is, from the patient perspective, I don't necessarily need to come into the office. I don't need to take that 4 hours for a 15-minute office visit. I can get the information that I need and sometimes get the questions answered and the care I deserve in a non-traditional visit. And I think that we have set that expectation in our own population quite differently. I wanted to highlight a couple other things. One is one of the main lessons we learned through the public health emergency is the value of communication. Not communication necessarily just between provider and patient, but communication from the payer perspective with our provider network and with our membership. So one of the early mistakes we made is we were not actively communicating with those 2 groups of individuals. And we received a flurry of calls and questions from both our membership as well as our provider network on things like, what can I do during the public health emergency to offer care? How can I get reimbursed for that type of care? And how are you going to change your payment models to help to offset some of the decreases I'm seeing in a face-to-face visit? And I think we followed the CMS guidance on one, showing the value of an audio-only visit and providing reimbursement for that at the same level as a face-to-face. But we developed a task force. It was the COVID-19 task force that met daily, which involved not just the medical management team from our health plan, but also payment guidelines, our communications, our marketing team. One of the things that it forced us to do was to make sure that the information on our website for both providers and patients was accurate and consistent and up to date. So we met daily and made sure that we were using multiple modalities to communicate with both our membership and our providers. And I think that made a world of difference because we saw that flurry of calls start to decrease dramatically quite rapidly. The other thing that we've done in our region is we've embraced value-based models, especially with our own ACO, and have looked for ways to pay for care through alternative models, not just a fee-for-service face-to-face visit. I think there's a tremendous amount of work that payers can do in that space beyond what we're already doing, so that the value of a telehealth visit or using telemedicine is realized. But there are two caveats to that, and I think this was mentioned also in the earlier panel. One is we have not seen any abuse of telehealth visits like most others have echoed on the panel. But the one thing that we see is variability in what a telehealth visit means. So whether it's audio only or video only, it would be nice to see us progress to something that is, this is a standardization for a telehealth visit. This is the components that you need. There may be even various different levels of what a telehealth visit pays. And also, what are the triggers needed for a face-to-face? And I think that's what we're missing from a quality standpoint. And that is what concerns me a little bit as both a provider and on the payer network side, is that we haven't quite established, and I think somebody mentioned earlier, what those guidelines are for a telehealth visit and what is an effective telehealth visit from a quality standpoint. So I think we are on this trajectory, but I think there's a lot of work to do in ensuring quality. And the other most important thing is, as a payer, what we've done is we've engaged other vendors, organizations to help surround the care the patients receive, whether that's our agreement with Teladoc, or even we have a telemonitoring program for chronic disease conditions. But what the pandemic has shown is that we need to drive those initiatives through the care delivery network to ensure that, one, whatever happens in a telehealth visit is easily accessible to anyone that touches that patient, and two, to make sure that all those different modalities are coordinated so that there's an awareness for the provider who's currently interacting with that member or patient to understand that they are receiving these other modalities, and make sure that they're enhancing that care rather than creating more disjointed care and inhibiting a comprehensive, holistic approach.
Well, thanks to all of you for your very insightful and very thoughtful responses to the first question, but you've now eaten up all the time for a lot of in-depth on the others. I'm going to give my my colleagues a chance to ask questions, and I think I saw that Jennifer, I believe your hand has been up since the last one, so I'm actually gonna, I don't know if that's real or not. I'm gonna start with Jay Feldstein, and if Jennifer, if that's real, just let me know.
Thank you, Grace. My question for everybody, but probably more directed towards Lou, is how do we make sure we're not creating another giant healthcare silo? Because healthcare is famous for developing silos, and especially among freestanding telehealth companies. How do we make sure that we get it integrated, and to what Chuck was referencing earlier, across the entire healthcare delivery system?
Sure. Thanks, Jay. So, you know, having, you know, sort of spent the past 32 years in practicing in Boston, and having actually admitting privileges at both the Brigham and Women's Hospital as well as the Beth Israel Deaconess Medical Center, you know, just amazing to think that here are two institutions that literally are sitting across the street from each other and do not share a common electronic medical record. So an individual could literally be in the Brigham emergency room one night and be presenting this next day with the same complaint and not having easy transmission of information. So that problem with interoperability, which folks have been talking about for over the past 20 years in terms of building out kind of this information superhighway, is still an extremely relevant issue as we get into the age of virtual care. So I think that interoperability, so that any provider, whether it be in a brick and mortar setting or be in a virtual setting, has total access to the information, and that the information is not siloed into individual hospitals, health systems, but is kind of more universally shared. So we're working with all of our partners. We have a significant, particularly with our recent acquisition of InTouch Health, a very significant investment in trying to enable physicians to take care of their own patients through our technology. And we feel as though this interoperability is key. We are also in the year ahead going to be launching, based upon a very successful pilot that we were able to do this year, our own virtual primary care offering. So the actual physician that would be that coach, if you will, that real head of the team, will be the patient's virtual primary care doctor, and will be able to obviously communicate effectively with the other members of the healthcare team. Also, with our coming together with Livongo, we basically feel as though these digital tools can now be leveraged to not only provide that information back and forth between patient and digital tool, but also digital tool to providers. So we really think that that's also going to be foundational in terms of the information sharing. Will this require new economic models? Yes. Will this require more attention towards value-based care? Absolutely. But we're really excited to go forward. But I think I could not agree with you more. What we do not want to do is to create a whole elephant that is totally in its own silo and not interdigitating with the rest of healthcare delivery.
Thanks.
Sure.
Thank you. Josh, you have a question next.
I do. Thank you, Grace, and thank you for everybody for your comments. My actually question is even on the other side of that, which is to say, one of the things I've appreciated from what everybody shared is the variation, not only in telehealth, but how it's applied in your local setting. So the difference between audio only, video audio, for instance, the idea of what really is telehealth, the notion some have raised that it really depends based on clinical area, maybe specialty, and it may differ by disease state, hepatitis. You've heard different things. And so silo is one thing. What I'm struck by is kind of the other side of, you know, 1,000 flowers blooming, everybody doing what they're doing here and looking for some alignment behind that. So maybe this is a rapid fire question, but I'm curious, what is the first bite out of the proverbial apple? How do we, as a country or regions or as a community, avoid silos, work together? But what's that first bite? Because there can be potential paralysis, right? Saying, well, there's so many dimensions on this thing that where do we start? And I'm curious people's thoughts on that.
Well, this is Lee Schwam. I'm happy to make a quick answer to that. I think that we need to understand how to deliver care in our integrated delivery networks in a way that incorporates virtual care, telehealth services very effectively and efficiently. So I think that is an ideal environment in which to ensure that fragmentation of care is not a barrier and is not an inadvertent consequence. But just like we have FedEx and we have the U.S. Postal Service, there are important roles for private players like Teladoc and others to fill in the gaps and to create care delivery models for patients who don't fall into integrated delivery care networks. So I think that it's really important that we think about partnerships, both demonstration projects with CMS, value-based care and alternative payment model contracts that are very attractive for health systems, rather than putting a lot of upfront investment and a possibility of shared savings at risk. We need to really create lower barriers to entry so that health systems embrace this. And if they have predictability and a 5-year roadmap, knowing that there's reimbursement in place, they can afford to make the investments to actually create lower cost and lower cost settings. If it's just a 1-year or 2-year demonstration, we don't know what's going to happen with the PHE expiring. Very hard for systems to invest in the kind of overhaul that we need.
Can I just
Go ahead.
I just wanted to, I just think what Lee said is so exactly right and so important, which is just, especially when I think about the populations that I deal with that have really complex care needs and lots of, they're interacting with the medical care systems, they're interacting with the long-term care systems. And, I think it's a mistake to say, gosh, you know what, we're going to assume that an investment in telehealth pays off under the current way in which we've structured APMs, that, we're going to, or, like everything can be solved if we just put all of, if we just kind of hand the risk over to these entities and then share in savings with them. We have to make it really attractive. Like, I think we have erred a little bit on too cautious of a side in terms of just ensuring the investments in the kinds of things that we know work. And so, making it more attractive, thinking about how maybe just to kind of like, you can, turn the dial back a little bit in the other direction so that it is absolutely a good investment for, a large player in a market, a large physician practice, not just to sort of embrace virtual care, but to also kind of build the care delivery infrastructure within their organization that can make sure that it's being used in a way that is, ultimately improving care for everybody.
Grace, is there a way I could take that a little bit?
Yes, please.
Yeah, this is Sanjeev. So one of the challenges, of course, is that as long as the reimbursement is purely fee for service, integration of these silos becomes very complex. So I think that really moving to alternative payment models or value-based care, or what you call accountable care, where the system is actually responsible for the entire care delivery of the patient and responsible for quality of care, responsible for patient satisfaction, responsible for the community health, then what happens is that integration becomes a natural consequence. Then it is against me if my electronic medical record doesn't talk to the neighboring hospital. But right now, the payment systems as designed are absolutely antagonistic to this idea of breaking down silos. In fact, they're designed to create silos. And so I think a much more fundamental change in reimbursement will be required to achieve some of the really great objectives that you outlined.
Could I just,
Sophia?
Yeah, could I just, sorry, Grace.
Yeah, so, Sophia, your hand was up, and then Jen had a question. So I wanted to get Sophia a chance to speak next, and then Lauren or any of the others. And then I'm going to do something different after Jen's had her question or the others. Is that okay?
Thank you, Grace. I just very quickly, I completely agree with the comments just made, and I would say part of making that shift, I mean, by design, shifting, like alternative payment models shift the economic incentives, right? So that payment to providers is not based on widgets or transactions, but it's actually based on clinical judgment and improving patient health. And I think part of doing that is really making fee-for-service less appealing. And there are probably some very unpopular ways to go about doing that, such as depressing fee-for-service payments. But I think to really be able to integrate telehealth into healthcare payment and delivery, and there's been a lot of conversation about telehealth being a tool and its own separate modality, which I think is really at the heart of the question that was being asked. It's really about integrating into existing alternative payment models, existing value-based arrangements that are already making fee-for-service less appealing, and allows the provider to actually provide whatever the set of services are that they need to provide to meet their patient needs, therefore reducing silos and reducing the fragmentation of care, et cetera.
Thank you. Lauren, did I miss you? Were you wanting to add to this conversation before we went to Jennifer? I don't want to disrupt if it's about this same string here.
Thank you, Grace. I was going to bring up the concept of really centralizing coordination in the community, which came up in the comments. Thank you.
Thank you.
Grace,
Okay,
can
Jen.
I just make one final quick comment about that, which is I think value-based care or accountable care is a natural home for virtual care and telehealth, no question. But I think we would leave with the wrong impression if we said it does not have a role on the fee-for-service side. so many of our super specialists, subspecialists practice in academic medical centers are inaccessible to many patients. A lot of networks now are carving out and creating restrictions around who can access care. And so, you know, I think those patients in New Mexico that Sanjeev was talking about, if there's a hepatitis expert in Connecticut, they ought to be able to access that patient. And many fee-for-service arrangements still exist between ACOs when they buy out components of care that they can't offer. So I don't think we need a new payment mechanism. We already have a payment mechanism in the RVU-based system that recognizes care complexity or time-based billing, and we have modifiers to reflect that the care was delivered over telemedicine. So just want to make sure fee-for-service doesn't get portrayed as a place that telehealth is not valuable.
Okay. Jen, I'm going to let you ask your questions. Chuck, I see that you've also got your hand up. After that, I'm going to see if we can stop it, because I think here's what I want the rest of you to do and be thinking of while we're finishing with this. I'm going to ask each of our expert panelists to have 2 sentences for which, if they were to be able to say directly to Secretary of Health and Human Services, what ought they to do going forward with respect to telehealth and alternative payment models. If you could write it down and say it, that's going to be the last thing that we get done here, because I think that'll help us with all the rest of the stuff you're doing. In the meantime, though, you got to think about what Jennifer's getting ready to ask, and then Chuck, what you want to say. So that's I can tell you're all multitaskers, so I think we're going to be able to do this. Jen, go.
Grace, thanks for the opportunity to ask a question, and hopefully this question will prompt a response also to the question Grace asked. So I'm struck by, thank you all for being here. It's been a phenomenal conversation. What I'm struck by is the perverse incentives of our current system that is hybrid, right? This range of fee-for-service to some in play alternative payment models, and the points that were brought up around some of our most fragile communities being the ones that end up having this perverse incentive to move from a virtual visit into the clinic, where, depending on the payment model, it may actually be a more expensive visit, depending on the arrangement. So if it's for a Medicare population, as was described, it might be familiarity and comfortability with the technology. For other indigent populations, including patients with Medicaid, and there's, as you all know, variable literature actually about this, so it is not without controversy. But what I will say is maybe reduced access to technology. So at the end of the day, our federal payers, more than anyone, should be interested in this because of that perverse incentive about site of service of care. So my question is, Chad, and you brought this up around trends that you're seeing. I'm curious about our current payment model and its perverse incentives and how that's driving all of the data around demand that you and others have described, Lee and Lewis, and how do we reconcile the data around need, demand, utilization with what's currently existing because of these incentives? Thank you.
Okay, so I'm going to let you all answer that. You called out a couple of the panelists, so you might start there. But before we do, Chuck, do you want to save your comments for the end, or do you want to contribute right here, since your hand was up?
I'll contribute right here very quickly. I think that, so our region is still heavily fee-for-service, but we've enhanced that with value-based agreements with our provider network. And I think that if we follow the old model of value-based agreement, here's a care coordination fee to do whatever you want with, I don't think we're going to drive anything forward that's meaningful. And to the point that others have made, I think what we're going to need to do is change the payment model and provide some type of funding for the network or for providers to deliver telehealth services, but we can't do that without having a very concrete conversation on here's the services that we bought, whether that be Teledoc or home telemonitoring from another organization, and we should have a conversation on here's what we as the payer are willing to pay for, and here are very concrete expectations for what we expect from you in the care delivery system from the standpoint of providing telehealth services. Here's what we provide, here's what you provide, and try to figure out how to get those together without, as everybody's alluded to, not making another silo of we bought this service that's way over here and completely disjointed from the care delivery system happening in the office.
Thank you. Jen, I believe you called specifically out to Chad and some others. Chad, do you have a comment here?
Yes, absolutely, Jen. That was an outstanding question, and I think that I can certainly speak to it. I think that one thing that is really important is that I think and this is brought up in the panel before. I think the three things that are really important for policy making related to telehealth is that the top three things are the impact on disparities, the impact on costs, and then the association of telehealth with outcomes, clinical outcomes. So those are the top three things. And so speaking to the disparities angle, which is what you asked about, I think that first was when we look at how during this pandemic, different populations use telehealth. We know that there is a digital divide, but yet when we look at, and we have access to state insurance data, and when we looked across the state of Michigan, we see that every one of those populations, like rural versus non-rural, low income versus higher income, in minority groups and so forth, what we see is that all of those groups did increase the use of telehealth during this time period, but there was a delta between those groups of interest and their counterparts. So there was a delta, but there wasn't any population, even populations over 80, that was significantly left behind with this adoption of telehealth. So that's an important point, is that all the populations are increasing the use, is just at a different rate. And so I think having this data up front, seeing what happened during the pandemic, actually offers policymakers a lot of insight into what will happen over the next 12 months, next 24 months, if there's no policies that are in place or interventions that are in place. And that could be at the federal level, or that could be at the local level. So knowing that older populations have challenges with using the technology, investing at the local level, investing in community centers, buyback programs for smartphones, subsidizing connected devices. Everyone knows about expanding the programs that are out there for expanding broadband, but then those are all patient level interventions. But then also at the provider level, there's providers in those communities as well that are not adopting telehealth as much as their counterparts. So, investing and subsidizing telehealth purchases or subscriptions to those providers in that area is going to be very important too. So those are just kind of some quick ways. I mean, it's obviously a big topic, but the fact that everyone's talking about it is really important. And that's really the first step towards mitigating that digital divide.
Thank you, Chad. I just looking at the time here and know that we've got several people from the public who are wanting to speak. I'm going to give you all just that one more minute now to think about the 1 to 2 sentences only that you're going to advise us as we're thinking about how we might advise the secretary. While you're thinking for a minute, let me give you my personal experience with telehealth, because I think it might be insightful. Typically, if we were actually deliberating on a proposal, we would all have to declare any conflicts of interest or anything else to disclose. It struck me while I was listening to this that I ought to disclose. I used to be a provider for Teledoc, have done about 5,000 visits in 2019 in about a 10-month period of time before COVID and before the waiver. And there were several things that I learned from that experience. One of them is that it actually met the need of a lot of people. This was typically in commercial insurance or those without insurance, not Medicare or Medicaid, who needed healthcare services that did not need to be provided in person, but yet they had no access. And so much of it was, there was a surprising amount of dental care need, many minor dermatologic problems, lots of mental health. You flip that to the year 2020, and I am the CEO of a company that has 650 assisted living facilities and skilled nursing facilities in 5 states that we had to provide to primary care, mental health services, and some other services overnight, like everybody else, to the most vulnerable and isolated population in the country during the epidemic. And that was a completely different telehealth experience to a completely different population. So I, for one, am a believer that it is a solution for many things. And I've had the experience both pre and post COVID. So that, hopefully that gave y'all time to think a little bit about your answers while I went on my soliloquy. And what I'm now going to do, and I will be starting with you, Sanjeev, is just give you just a moment, give me 1, 2, or 3 sentences on what do you think with respect to alternative payment models and telehealth that PTAC needs to advise the Secretary.
Yes. Well, thank you, Grace. I think that what I'd like to say is that in addition to direct telemedicine models, which are extraordinarily useful in overcoming geographic barriers to care and taking care where patients need it, we have another very major problem confronting the health system, and that is the exponential growth of new knowledge and constant change that is occurring in this knowledge. So a primary care provider or any physician living in a town in the United States doesn't have the ability to keep up with that information. So we have a great opportunity to use telehealth for technology-enabled collaborative learning models where people can learn from each other, where we can carry the latest knowledge to the last mile of healthcare, and then use telehealth not just as a revenue enhancing model, but use it as a way to provide the right care at the right place at the right time. And sometimes it'll be telehealth, sometimes it'll be direct care, but for any kind of care to occur effectively, Grace, what you need is the right knowledge at the right place at the right time. Without that, no technology can solve the patient's need adequately. And for that, we need new payment models. Thank you.
Thank you. Anne.
I think I just say what he just said. This is transformative, without question. It's very exciting, but it does require a lot of flexibility. Really kind of much more, greater degree of courage on the part of policymakers in allowing for more flexibility and investment in both fee-for-service and alternative payment models. And we have to, the long-term care population is going to get stranded if we don't do a better job of promoting investing in the APMs that actually support the primary care-led multidisciplinary teams that serve this population. Like that, we can't, telehealth isn't the solve. It is the thing that will help the solve work and scale. And so, now we know we have this tool. Let's really double down on those models that we know work and the payment systems that support them.
Thank you very much. Chuck?
So mine's going to sound pretty similar too. I would say support models of care that provide defined guidelines for appropriate use and ensuring quality. And most importantly, and you may have heard this before in the last comment, but support a payment model that allows flexibility. We don't want a one-size-fits-all to be blanketed across the entire population of the United States. I think that different geographies have different needs, and we have to have flexibility built in. So I'll end there.
Thank you. Louis?
Well, I think it all boils down to you never let a serious crisis go to waste. And I fully believe that right now, in terms of 2 specific recommendations, they would really be along the lines of parity with regards to reimbursement between in-person care and virtual care, and also supporting infrastructure that really facilitates integration of virtual care with in-person care to address the issues raised before around interoperability.
Thank you, Lee.
Simply put, remove the barriers to virtual care so they are treated similar to in-person care, expanding the access for either in-person, virtual, or a mixture of the two. It's just really simple. Just make it simple and make sure we don't build a system so arcane and complex and Byzantine that patients are getting surprise bills or lack of access, and providers and facilities are at constant risk of non-compliance when they're simply trying to do the right thing. It's really simple, actually. Just treat it like any other kind of care.
Wonderful. Chad?
Thanks. So Lee said it better than I was probably going to, but these are my 2 points. One is that simplicity is extremely important. So fragmented coverage and over-regulation is why less than 1% of Medicare patients have ever used telehealth, even though telehealth was actually covered and paid for in the last 20 years. And it's because of these. Your patient has to go to a certain location, has to be in a certain area, that the path of least resistance has been not to use it. So simplicity is going to be extremely important for policymaking. And then the second important point is that as you think about the sort of paying for telehealth coverages, the financial gain from using telehealth must outweigh the costs of using it, and whether the costs of implementing it, whether that's in a fee-for-service environment or whether that's in an alternative payment model. In order to think about that, you have to think about the entire episode of care. So it's not just reimbursing for remote monitoring, but also the interventions that that are needed to help get that desired outcome, whether it's community paramedics or home infusions, whatever it may be. Thanks.
Thank you. And Sophia, you started us with your marvelous, thoughtful approach on as a patient advocate and thinking about disability. So I'm going to let you finish with your advice to the Secretary.
Sure. Thank you so much. And thank you for the opportunity for families to be here today. Just three points. I think the first, as we've heard from others, is unleash the data. It needs to flow. It needs to be interoperable. The second is integrate telehealth into existing alternative payment models that are already shifting the economic incentives to be prospective and capitated, et cetera. There are already models that are doing this, CPC plus track 2, primary care first. And then third, when we're building, modifying existing APMs or building new ones, leverage them to reduce the digital divide, get direct support professionals, including community health workers, patient care navigators, social workers, into the care teams so they can work directly with patients and help provide e-literacy skills, et cetera. And then, figure out how to leverage APMs to get technology into patients' hands. And when providers are not relying on fee-for-service and are in an APM, the shifted economics allows them to get a tablet, get a computer into their patients' hands so they can actually overcome some of that digital divide. Thank you very much.
Well, you've all been wonderful, and I want to thank all of our panelists for their keen insights. We are grateful that you've shared your time, experience, and ideas with the committee and with our audience here today. As Jeff said this morning to our previous panel, if this would be the point in the Great Hall that we would ask for applause, but I'm just going to give you snaps right now. So this is awesome. So at this point, I'm going to turn things back over to Jeff as we're going to move into our public comment period. Thank you all very much.
Thanks, Grace. And I echo your appreciation for the panelists. That was great discussion. Look forward to digesting it, and hopefully we'll be incorporating that feedback into our evaluations of upcoming proposals as we move forward. So really appreciate your time today and expertise. That was awesome. We're going to move into the public comment period, as Grace said. We have, I think, 5 folks who are signed up. The rules of engagement here are each commenter will be limited to 2 minutes if we could. The folks on the staff will unmute each individual after I call them, and then feel free to go ahead and start commenting. So first up is Harold Miller, who's with the Center for Healthcare Quality and Payment Reform.
Thanks, Jeff. I appreciate the opportunity to be here. Can you all hear me? It's very clear from your discussion today that in a large number of circumstances, telehealth is a highly beneficial service for patients, and in a lot of circumstances, it's an essential service. It's also quite clear that telehealth can't be delivered if they are not paid for, and until 6 months ago, most telehealth services were not paid for. Today, Medicare is paying separate fees for those services in addition to all the other thousands of fees it pays for office-based services. That's a payer-centered approach, not a patient-centered approach. The patient-centered approach is to pay providers to diagnose or treat a patient's health problem in a way that gives them the flexibility to use whatever approach or location will have the best outcome at the lowest overall cost. A number of physicians and provider organizations have designed payment models that would do just that, provide flexible, patient-centered payments tied to outcomes, not to specific places. PTAC has recommended a dozen of these models over the past 3 years. Unfortunately, CMS has not implemented a single one of these models. If CMS had implemented them, tens of thousands of patients could have been benefiting from telehealth services long before the pandemic. CMS has said that it would take them years to implement PTAC's recommendations and that they don't have the bandwidth to do that. Miraculously, though, CMS found the bandwidth this spring to issue over 100 pages of regulations, making 50 separate changes to Medicare payment rules, more than 24 of which were related to telehealth. It certainly didn't take physicians years to implement the changes. Almost overnight, the use of telehealth services skyrocketed. It was clear that the payment system was the biggest barrier, not physician or patient resistance. It shouldn't require a pandemic in order to get the changes in payments that will help patients get better care. Congress clearly needs to change the law so that CMS is required to implement more physician-focused payment models more quickly. And I urge PTAC to recommend that to Congress, that they change the law in the report you issue after today's meeting.
Thank you, Harold. We're going to go with Gretchen Alkema with the SCAN Foundation. Thank you.
Jeff, Gretchen dropped off. They're trying to reach her. If you could go to the next one, please.
Thanks, Grace. We have Keisha Houston, a researcher. Keisha?
Yeah, I listen to everyone, and it's a joy to be here. It's not speculating, but it's kind of inspiration to see how these is addressed about what we need to do and how more proposals need to go out as far as asking into what need to be accommodated, especially one gentleman had brought out about payment issues. Now, on reductions of collaborating, a lot of issues with reducing payments because of certain states is not paying, it becomes an issue with others, especially when it comes to, we have to, ask and try to find certain areas that will help. And it's not easy. So we just do what we have to do, and some of these questions is an inspiration about, about trying to collaborate and trying to be more, into what things need to be done. So, yeah. I'm new at this, but it's just the questions that have been issued as far as payments and what can be paid, what cannot be paid, say for instance on dialysis or other issues that has been, brought up. It's just it's trying to find, who will, or who can be asked for, this mission to happen. But, as far as it's concerned, it is going to be taken care of, and just an inspiration as far as everyone's issuing, broadening out to what needs to be done. And, we're going to do more better than what we do then. Thank you.
Thank you. We have Kelly Garber from the MUSC Center for Telehealth. You're next. Kelly, are you with us?
I'm muted. Hi, can you hear me now?
Yes, we can.
Thank you. I appreciate the opportunity to share some thoughts with the group and enjoyed the discussion, and it was very informative, and I appreciate that. I'm speaking today on behalf of nurse practitioners, particularly the National Association of Pediatric Nurse Practitioners, where we're experts in pediatrics and advocates for children. As everyone has shared today, telehealth is an efficient and effective method of care delivery. I've seen firsthand the difference it makes in the lives of children and families, particularly those with special healthcare needs and chronic conditions. It's important that barriers to telehealth utilization continue to be removed, including those resulting from lack of reimbursement. It's very important that any reimbursement modifications be inclusive of advanced practice registered nurses, in particular nurse practitioners. Nurse practitioners of all specialties provide quality, comprehensive care. Extending the reach of their care beyond clinic walls may make a significant difference in improving health outcomes and health equity. Including APRNs in telehealth practice can make an alternative practice model more efficient and patient-centered. As healthcare continues to shift towards value-based care, it's crucial that APRNs be included in payment models that are flexible, innovative, and improve patient outcomes. Telehealth can contribute to the success of these models. Using various modalities of telehealth to extend the continuum of care may contribute to achieving the quadruple aim of improved outcomes, improved clinician experience, improved patient experience, and lower healthcare costs. Using telehealth to reach patients where they are, such as children in school or in their homes, may improve health outcomes, reduce the frequency of unnecessary emergency department visits, reduce cost, and reduce missed work time for parents and class time for students. It's time that we reimagine healthcare. Embracing telehealth and being inclusive of nurse practitioners is essential to the future of healthcare in our country. Thank you.
Thank you, Kelly. And that actually concludes the public comment section of our meeting. And I'd now like to turn it over to, as we close out this incredible day, we have some time for the committee members to discuss and reflect on what they heard today. The learnings from our sessions and discussions here today will be compiled and shared online and with the Secretary of HHS. Similar to when we wrap up our deliberations and voting on proposals, I invite my fellow committee members to share any additional insights or specific points that we would like to emphasize in our report on telehealth. Thank you. So I open it up to the committee. Just anybody can just go ahead, you guys. There's just a few of us here.
I'll jump in, and thanks for the opportunity to ask questions. I guess much like Grace did, I guess I should, for the record, disclose a potential conflict of interest in that I am a co-founder of our Health Systems Care Innovation Center, where we partner with digital health companies to grow and scale their solutions. And I believe strongly that payer, provider, and technology partnerships are critically important to help us solve these issues. And I think we heard some wonderful best practices that are working well. And I think alignment around identifying care models and the message that it's not one care model, it may be multiple care models based on patient preferences is an important consideration. And then how the payment model aligns with those care models. Again, it may not be one solution, but it cannot be 20 solutions, right? At some point, there needs to be simplification of the process We have many tests of change that are working, and I think COVID has given us the awesome opportunity to see when there is a crisis, we can move quickly to improve the health of our patients across the United States and ultimately our population. So we can do it, and I hope that some of the tactical components that were described here, that we can highlight and leverage this as an opportunity to make some significant change or influence change.
Thanks, Jen. Josh, do you want to go next? Josh, can you hear me?
Oh, yes. Sorry, Jeff, there was a little glitch on the web there. So my comment builds on Jennifer's, and it's that the two things that really struck me from this last session were this idea of flexibility, but the need for simplicity. And I don't think those are necessarily at odds on their faces, but does highlight the potential tension between kind of having many different tests of change that can be useful and then moving towards a place where, as others have said, we can't have 20, 30, 40 solutions. And so the thought I'm left with is this idea of sequencing and how we think about when, how, and where do we encourage more flexibility, perhaps at the cost of simplicity, recognizing that, versus when and how do we move towards simple solutions that can be scaled, but recognizing that that may come at some level of less flexibility. So I'd love that to be reflected in our report.
Great, thank you, Josh. And I think we'll have time to sort of look at the draft and make sure that the points that were raised by the panelists in both panel sessions get incorporated. There were a lot of tactical comments that were made, from security, sort of tracking challenges, technology challenges, to more global concerns that were raised regarding payment, parity, a patient-centered approach, as Harold pointed out, and interoperability. And not the one thing that I think, Jay, you raised about the silo. The last thing we need right now is creating a silo, yet another silo. So, you know, an electronic health record sinkhole, or now it'll be a telehealth sinkhole. We definitely don't want that. And so here's an opportunity, since we're starting, you know, we're just putting up the tracks now, we're laying the tracks. We have an opportunity to get it right. And so I'm hopeful that the guidance that we can provide in this document that we're going to create will help us get to that end. Any other comments? I didn't see anybody else raise their hand. Grace?
Yeah, just one thing that's not specific about the actual topic today, but just an insight that I had with just the richness of this discussion as it relates to a topic, by having not only the just the very thoughtful comments from the previous submitters this morning to the expertise this afternoon, created something I hope we can think very deeply about as a committee as we're going forward with our ongoing you know, processes and thinking through. So I know we'll likely talk about that a little bit more in our administrative session among ourselves, but I just wanted to say in the public meeting that I, for one, found this to be rich and useful and beneficial, and would certainly want to find out from the public if, as and other, you know, all the stakeholders, whether whatever work product comes out of this after we talk in more detail in the public meeting in December about this, as to whether this is something that we need to do on an ongoing basis. I believe it is, and we as PTAC, of course, are thinking about what might be our next thematic meetings, but this is our first, and so I think it's going to be really important for us to understand from everybody, is this going to be useful going forward? I, for one, thought it was wonderful.
Thanks, Grace. And I know, Lauren, you had a comment you wanted to make, or a question.
I thought this was incredibly rich. Jeff, there's a few themes that were really striking to me. So first of all, how aligned everyone was in their comments across sectors was very interesting to me. And then how valuable telehealth has been with behavioral health is a theme that's coming up around the country, which I didn't expect. And then the emphasis on the interprofessional, interdisciplinary, and interorganizational collaboration and design of that in what we look at with telehealth. And then finally, the transformational value of including the perspective of startup costs and education or co-learning when we look at financing telehealth.
Thanks, Lauren, and thank everyone. I mean, this was a little bit of a, we were astronauts today. This is the first time that PTAC has embarked on a session, holding a session like this. But as Grace said, it's been incredibly rich, incredibly valuable. It will help sharpen our thinking and our approach to evaluating models and making recommendations on the go forward. I want to thank everybody for participating today, members of the public, panelists, public commenters, and obviously my colleagues on the committee. We've covered a lot of ground today on a very important topic, and you can keep an eye out for our resulting compilation in the coming weeks. We're also issuing around another round of questions for public input, as Grace pointed out, and this time focused on telehealth. And we will be posting those online and sending them out through the PTAC distribution listserv, which you can join on the ASPE PTAC website. Thank you all for taking time out of your busy schedules to join us. Please take care and be well. And this meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.